right, so now your kidneys. Just, I guess this is something that I put up just to point out a couple of things, because one, your kidneys got nothing to do with alcohol. I always get asked about, do I have to stop drinking now that I know I've got this? Then you may be needing to stop drinking, but it's got nothing to do with your kidneys, because that's the liver. So you've got two kidneys. They sit at the back underneath the ribs, and they're composed of, they're very intricate structures with lots and lots of very complex functions. When you have angiomyolipomas in the kidneys get quite distorted, and it's extraordinary sometimes that you see CT scans, MRIs of patients who have AMLs, just how big those AMLs are, how much of the kidney space they seem to occupy. But you do a blood test, and the blood test is remarkably close to normal. So I think that that's an extraordinary thing, and it's very important to remember that even though you may have multiple lesions, that your kidneys can still continue to function and clear waste products and make urine quite normally. AMLs can occur anywhere within this cortical area of the kidney, and they can occur in both sides, and they're usually multiple, and they're usually very complex. They look a bit crazy, and I'll show you a picture of that because they're very disorganized and they're everywhere within the kidneys. So the kidneys frequently get angiomyolipomas. It's one of the major diagnostic criteria for tuberous sclerosis, and it occurs in about 80% of people who have TSC. Cysts occur within the kidneys as well, and I guess some of you might know that the TSC gene is very close to the polycystic kidney disease gene, and that in fact some people with TSC actually have a mutation which involves the polycystic kidney disease gene, and they actually have both of those diseases and develop very large cysts within their kidneys. But just because you've got cysts as part of, people with TSC get cysts as well. So even if you've got cysts, don't be worried that you've in fact got two diseases now. You do not necessarily have polycystic kidney disease, because the natural history of that disease is very different from tuberous sclerosis. But some small subset of people will actually have both diseases. And these are very common, and you see them not infrequently, and they're very benign, and I will talk a little bit about that. There's been, of course, a lot of focus about cancer, and it's very interesting to hear the story before from Brie about the fact that someone told her she had cancer, and that's not infrequent. So that very commonly happens, and we've, even in our small series of patients, again, had people who've come through that same very distressing pathway, and it is very distressing. Cancer does occur in tuberous sclerosis, and then for a long time we thought that perhaps it was more common, but probably what happens is that yes, people have it. It might not be that much more frequent than the background population, but it occurs at younger ages, at ages where you would not expect people to be developing renal cell carcinoma. Okay? So people are always looking for this because it needs different treatment, and it's sometimes very difficult to diagnose because the kidneys look so abnormal already that it's a little bit difficult to use all of the clues that people who look at these x-rays and neurology doctors use to be sure that this is not a cancer. It can be quite difficult, and we spend a lot of time going over x-rays with our radiology colleagues and going back through lots of old x-rays for patients to see whether we can try and get any clues, whether or not there is something happening that looks like a cancer. Now again, I think it's also really important. People worry, of course, that when you have kidney diseases, is this going to progress? Am I going to lose my kidney function? Do I have to think about kidney transplantation, or dialysis? And again, this does occur, but the number of patients this affects is actually remarkably small when you think about how distorted the kidneys are. It does, of course, occur. It's very important. But again, just because you have tuberous sclerosis with AMLs doesn't mean that your kidney function is going to be lost, all right? And in fact, a huge amount of what happens is to try to protect your kidneys and preserve your kidneys from being damaged. And they can be damaged if you do have the gene with polycystic kidney disease, which is rare. There are subsets of people with tuberous sclerosis that have an unusual, what's called a phenotype. They have an unusual pathway to progression where they seem to have abnormalities within the kidney. They don't even always have a lot of AMLs, but they have very abnormal kidneys that do seem to progress, and that's a very small number of people. you have to watch what interventions you do. And in fact, I think the thing I enjoy most about having access to the mTOR inhibitors is so we can stop people having destructive things happen to their kidneys, having embolizations, having kidneys out. And I think the biggest part of the message I try to get out when I talk to my colleagues is that we should try at all costs to avoid those interventions, and I'll talk a little bit more about that. And again, because I'm a renal physician, monitoring people's blood pressure, that's what I do, that's my job. And I think it's really important that that's brought in to the monitoring of people with tuberous sclerosis, is that because this is something we can treat, it's something we can do, and it does occur. And in fact, people on Everolimus and sirolimus, that puts up their blood pressure a little bit. It's not a big factor. So you've seen a picture before. We love having pictures of what the kidney looks like, and this is what an AML is, and I've put it up. So they're typically made up of, the vessels, which is angio. So this is a blood vessel here in the middle of an angiomyolipoma, and they make these crazy pathways and networks of blood vessels. And yes, they can bleed, and I'm going to talk about that a little bit more. This clear stuff here is fat, and we actually like to see fat in these lesions. Probably one of the places you really do love to see fat is in one of your AMLs, because we relax a bit when there's fat, because it's the fat poor ones that you worry about, that they're atypical and there may be a higher risk of them being cancerous. So love a bit of fat, that's great. And then there are all these abnormal spindle-shaped cells down here. So about 80% of people with TSC will have AMLs of various sizes. Okay. And actually, my other major point that I like to make over and over again is that a lot of people with TSC and AMLs will not have major problems. And I think this is, again, something that's really important. It's very important, as Lisa said, not to miss the people who are heading down a pathway of trouble, but we need to be sure that we don't overtreat people who don't need treatment as well, again. All right, so this is, Sean gave me some of these slides, which is very kind of him, so that I could at least make some effort to speak about children. So these are from 2010, where they had 63 TSC patients, and they found that 50% of that cohort, of that age group, were able to find AMLs. And you can see that they slowly increase in percentage in time-wise, I guess. And again, there are so many unanswered questions. And one of the ones I always have is, what starts these off? Why do they start at some age in some person and another age in another person? Why do some of them just steadily grow till the mid-20s, or some of them will be okay, and then they'll have a growth spurt, and then they'll back down again and they'll stop growing? And we look at a number of people now that scans, like abdominal scans, have become quite frequent. Like, you've got a bit of tummy pain, someone thinks you've got a gallstone, they'll do an ultrasound, and we find these people who come in who've had no real problems in the past, and they've got these big AMLs. They're huge, they're just sitting there, and they've had no problems their whole life. I look after one woman who's got big lesions that are 20 centimetres, and she does have TSC. You go back through her history, and she had very mild epilepsy, which was treated, and she's had no problems with that. She's got a few facial lesions, but she really didn't have the diagnosis made until she was in her late 40s, and she's very stable now. So how do people get where they are is very different. And in their group, that 3 of those 63 were symptomatic. So this is the consensus guidelines, and I think it's important that you will have come across these many times and be very, very familiar with them. So I put this bit down in here in red because this is my just kind of take on the practical way of managing people. MRI of the abdomen is important, and that's a great modality. You can see fat really well. You can do the radiologists can do lovely things with different phases of blood flows and different things to get a lot of information out of an MRI. But sometimes MRIs are not practical. I mean, we've got patients who are just not able to tolerate the claustrophobia of being in an MRI, getting access to MRI. I'm from Queensland for my sins, and if you live in Thargomindah, getting an MRI is a really big deal. It's a long way to go. You've got to book in a few months in advance. If you have a cold or a flu that day and you cancel your appointment, you've got to wait for another 6 months till you get your next one. And that doesn't mean the system's right and can't be made better. But Thargomindah's never going to have an MRI. But ultrasound in the right subset of patients very carefully can be substituted in at times. So this is a pragmatic approach that we use, and I put it in red because it's not exactly the same as this, but it can be okay, and we do use it for stable lesions. So you can pick up if things have changed a lot, like if there's been a big change in growth. We use it more in our older patients who look like they've had that growth trajectory and they're now sort of in a more stable pattern of their disease, so we do use it for that group of patients. But the caveat for this is not great at fat-poor lesions, and that's the ones you really want to watch closely. That MRI is much better at picking up fat. And it's much better in uncomplicated patients. If you've had embolization, you've got coils in everywhere, sometimes you just can't see enough, and it's just not practical to use an ultrasound. So in the real world, we use a bit of both. So what happens to AMLs? So this is actually, sorry, I forgot to put the reference down here. This comes from Chris Kingswood's group before they had mTOR inhibitors. Okay, so it's quite an old study. But they took 102 patients, so sort of just rounded it off to 100, to see what happened to those patients across time. All right, so they all had renal AMLs with TS, and they wanted to see, right, growing in size. Okay, how many of them bleed? So out of their 100 over the period of time that they followed, 6 out of 100, or 6%, did bleed, and they could be quite significant bleeds. The risks of bleeding, as has been described before, were those lesions that were larger than 3.5 or 4 centimetres. But this, just because you've got a 4 centimetre lesion, doesn't mean it's going to bleed, all right? That's really, really very important to remember, because there are other features of those lesions which are important. The ones that are growing rapidly are the ones that you want to intervene on and to do something about. And if you can see lots of abnormal blood vessels, then you start to worry a little bit more. But if you have a stable lesion which has been exactly the same on your MRI last year and the year before that and the year before that, then that lesion, in terms, even if it's bigger than 4 centimetres, is not the same as a lesion which was 2 centimetres, 3 centimetres, 4 centimetres, 5 centimetres, or if you've had a previous bleed. So again, part of what we do, I guess, and I'm giving you my story as part of this as well, is to work out where risk-benefit lies. Sometimes the blood, when they do bleed, is all right. So how do I know if somebody's having a bleed into one of their AMLs? Now, they range from lots of things. They can be just little bleeds where you'll get some pain. Not all pain in these AMLs or your kidneys will be from a bleed, all right? But if you have pain in one of your kidneys, which is typically at the back, but sometimes it's hard. In some of our non-verbal patients, change of behaviour, lots of, working out what pain is can be difficult. So you have to think about that. It can come out in the urine. Surprisingly enough, it doesn't do that very often. Mostly people present because they're dizzy or faint with abdominal pain, all right, when they have a bleed. Then present to the emergency department, and I'll talk about what we do in those cases. People can have pain in their AMLs, and that comes for a number of different reasons. Sometimes they're so big that they squish the normal-looking kidney, and they can put pressure on other abdominal structures. And in this series of 100 patients, they thought that sort of symptoms were seen in 2 of that group. But it's really important to remember that in this series, only 86% of people didn't have any symptoms at all during that study. So, therapy. Embolization followed by corticosteroids. So yeah, look, if you're going to do an embolization, I'll talk a bit more about that. And as part of the guidelines, which I think is really important because I've put it in bold, is that if possible, trying to avoid surgery is important in terms of cutting out bits of the kidney. So look, you can't grow a new one. There is some reserve in kidneys, but if possible, not cutting bits of it out that's the goal. And that the recommendation for an mTOR inhibitor is for asymptomatic but growing AMLs is very important, larger than 3 centimetres, and that if you need, you have a symptomatic lesion, that embolization is important. Okay, so they're the blood vessels in the kidney. So the kidney is a very vascular organ. It's really important to remember that the job of the kidney is to filter the blood, to remove the waste products and to make urine. So therefore, all of the blood has to go through the kidney. So every time your heart pumps, a quarter of that pump is destined to go to the kidneys, all right? So that's how much blood flow is going through the kidneys all of the time. So very, very vascular organ. So therefore, if you have a bleed from an abnormal blood vessel, you can pour out quite a lot of blood from that. And that's why people, of course, are worried about this complication. And you can see that there are some abnormal blood vessels. I think it's actually much better shown here. So what you can do when you do an embolization is you put a catheter into the blood vessels and you put some dye in so you can outline where those blood vessels are. And you can see this is a huge AML here. And just look, this is like more normal blood flow down here. Just look how crazy, there's a big pool of contrast here, lots of little blebs and things up there. They're the ones that you worry about that might pop and bleed, okay? So then what you can do is that you can, I'll go back a bit, you can put a catheter in and block off the abnormal blood vessel, all right? But that does cause that whole lesion to die, okay? So the radiologists have got very much better at getting their catheters in here to the right blood vessels. It's called selective embolization, so that you try and minimise the amount of kidney that's going to be damaged by this, that you're just going to try and block off just that AML, all right? So they got much better at doing that. But that AML will then die, and it can cause symptoms in of itself. They put coils in to block it off. So we often treat people with steroids and pain relief to try and cover that. But then they shrink down. So bleeding is very rare if the lesions are small, less than 3 centimetres. Treatment is recommended for growing lesions larger than 3 centimetres with some thought and consideration. So one other thing that I think is good, this slide, I'm sure you'll have seen this, is from the EXIST-2 trial, and where people were treated with Everolimus, as I'm sure you know, and looking at the size of their AMLs across time. And people always leap immediately to this graph, all right? Because this is the side where people were treated with Everolimus. This is the line of no change, and these are lesions that shrunk. And you can see truly a remarkable effect of this drug on the AML size. But I think it's really good to look at this graph, all right? Because these are the people who received the placebo. So they got no treatment. Some of their lesions got smaller, and that may just be because, or for lots of reasons, but this is a subset that I was always interested in. So out of all the people in the trial, these are the ones that grew during the time of the study, which, you know, that was a significant number, all right? There was certainly a clear difference between the two groups about those that grew. But there were some people whose AMLs which were not growing, all right? So it's very important to remember that that assessment is part of the decision-making process. Now that just leads me on, you've seen this so many times, that we can block mTOR, all right? So let's talk about how that is. So actually one other thing, I guess, to make is that the pathways that are affected include cell growth, all right? So this drug blocks cell growth. As we heard beautifully before this, it does not cause the cells to die. It's what's called cytostatic, which means cells stop growing, all right? Or something similar. Anyway, so this is the trial which was published very early on about sirolimus therapy, and you've seen something very similar to that, is that you see the shrinking in the size or volume of the AMLs, and then when the drug is stopped, the lesions get bigger in size. So that's very important. This is a cytostatic, or a cell stop growing or get smaller for a while, but you don't make these cells go away. So when you're making a decision about putting people on mTOR inhibitors, you have to be very mindful that this is what you're doing, all right? That you are not making these cells disappear. You are treating to shrink the size of the lesions, all right? But people are going to have to stay on the drug to see that effect for the longer term, at least as best we know now. So I talked about that. So yes, now we can look at this lovely, very exciting. I was actually at a meeting in America when this data was presented, and it was just truly amazing to get someone up there presenting such an exciting trial, particularly in kidney disease. We don't have that many exciting trials. We have a lot of negative studies, so it was terrific to see one which was positive. All right, so it is available in Australia on the PBS, which again is a fantastic outcome, and I think we shouldn't underestimate that we have a great tool to use in this disease. So before I start, actually the slides have got slightly out of order, I always just make a comment to tell people that you have to remember that this is an immune suppressant drug as well. It's not just going to affect those AMLs in your kidneys or your LAM, whatever. It does affect other cells in the body. So you have to make sure I always check people for hepatitis B and C and HIV before I start them on drug. These are a few little practical tips about what I actually do, because there have been people who, because it is an immunosuppressant, who've had hepatitis that's been quiet in the past because they were born with it, that can reactivate. So it's really important to remember that this drug does lots of different things. You talk to people about routine blood tests. It's not safe to use this drug, I don't think, in my own opinion, if people can't have blood tests, all right? I think you have to be careful with it. You don't have to check them every 5 minutes, but you do have to be able to check their blood tests. I spent ages teaching people about what a trough level means, and I think out of all of the concepts, I find it most difficult. And I understand taking people with TS to have a blood test is complex, all right? But it's really important that we do the blood test just before the next dose is due, so we can see and monitor. So we've got some idea. If you have a blood test 1 hour or 5 hours or 2 hours after they've taken the tablet, it's quite hard to interpret, well, it's impossible to interpret what that level actually means. So doing it before the next dose is really important. You have to monitor the effect on blood cells. We also monitor the effect on blood sugars. In adults, we monitor the effect on cholesterol, but in children, some of those things are a little bit less clear about what that means. And again, this is a point I actually really wanted to make as one of the take-home points. It's really important to check the urine for protein, all right? Sometimes I think that doesn't get done as well as you should, because one of the side effects of these drugs is that they can cause protein in the urine, and it's really important to make sure that that's checked for. Yeah.
I've had a big bleed at 29 from
Yep.
a huge AML.
Yep. Yep.
And I have renal colic.
Yep.
And then my disabled son, he was going around like this.
Can you ask a quick question into
Yep.
the microphone for
He,
everybody?
what I want to say, no, what happens if you get protein and heavy blood? Huh? Is it on?
Right. If you have protein and heavy blood?
Yes, yes, I have.
Right.
Intermittently. I check it myself.
Right.
I can tell when I have blood.
Right. Okay. Yep. All right. Yep.
Summary of what you think the question was.
Yeah. So I think the is what happens if you've got blood and protein in your urine. Yep. Yeah. That can be there for lots of reasons. So that's something that you need to work out why you've got that. All right. If you're on Everolimus, you don't tend to have blood in your urine. You have protein in your urine, all right? So blood and protein can come from lots and lots of different things, and that would be important to talk to your doctor about what, in your case, is going on when you have those episodes, okay? Yep.
Oh, okay. Yeah, they've been going on for a while.
Yep,
and
okay.
I just monitor it.
Yeah,
And
that's
so
okay.
When I go to the LAM clinic,
Yep.
it's on the list.
Yeah, that's good. That's good. You know, they're doing it. That's what's important. But that's the first piece of information. Yep. Okay. Okay, that's all right. So I think that's important. Yeah, so remember and remind. I tell all of my patients, including my transplant patients who are on drugs where there are drug interactions, is that you know more about the interactions than many doctors that you will see. So I always just ask them to remind their doctors when they are starting a new medication, just to check whether there is an interaction with Everolimus and to monitor and treat blood pressure. So this is again my approach. So when we see a new patient, I spend the first clinic, of course, just doing an assess and discuss, all right? Because these drugs are associated with significant side effects. The duration of therapy is probably going to be long if they are effective, and that decision making around the commencement of the drug is absolutely pivotal. The decision one, what are you treating? Why are you thinking about treating this patient? What do people what does everybody, both the patient, the family, and you expect that you might achieve with treatment with one of these drugs? If we're doing if we're looking at growing lesions, we get all of the old x-rays out and we sit there with the radiologist. And again, this is real world. Some x-rays 5 years ago were done at this place, and then there was some from that place and different systems. And now that people have got computerized and things come on a disc, it's actually really very difficult sometimes to get all of those images and onto the same system, and they're compatible and you can put them all up and compare them. So that is a tricky thing. So this is why this is a long clinic appointment. Then there's a gap while we get all of the information and we have another meeting to look at the pictures. Because this is the point to do your thinking and your decision making about what the benefits are for treatment, and it can be tricky. I then do the baseline blood tests, and I'm sorry I got that slide out of order. I check for hepatitis and other infectious things, look at what other infectious complications patients have got. I've got one TSC man whose love of life is swimming, and he gets terrible ear infections and sinusitis, but he loves swimming. And so, you know, we worried a lot about whether or not we should put him on an immunosuppressant drug. He's had to have surgery to drain out his sinuses and so on. So again, that was part of the decision-making process. Then when we do make the decision to start, and I always make sure I've got a baseline urine test to check whether there is any protein there to start with. Then I start at a low dose. And again, when we came back from seeing all that great data presented in America, we started the same dose that was in the trial and we got more side effects. So now we actually start at a lower dose and go upwards, because we thought that if people will tolerate the drug, particularly where there's intellectual difficulties or behavioural problems or in non-verbal patients, giving them a drug that makes them feel sick or gives them terrible mouth ulcers is not it's not a great start. It doesn't make them want to come to see you and come to your clinic. So I start low and increase, and I'll be really interested to talk to other people who are here just to see how they do all these practical things. We check levels, kidney function, white blood cells, and then I usually just rescan at about the 3-month mark to see what the impact of the drug has been. And I'll show you some pictures in a minute. I sometimes increase the dose depending on the response and the tolerability at that point in time. Occasionally I've actually had to down titrate because people have had symptoms and then work back upwards. We've had one young man who was in fact diagnosed with his TS when he was out running, and he kept getting abdominal pain when he was running, and then he had a scan to look for why that was, and he has bilateral renal AMLs, and he's on a low dose because he got terrible headaches when we put him on the higher dose. But we're now working it out, and have someone on 15 milligrams a day. The other controversial thing is to talk about what do you do when people are stable, when they've had scans and they're stable, and you think you've achieved a good effect. Should we start reducing the dose in some of those people? And the people have one boy in particular, the mouth ulcers have been quite difficult for him. He's at university, and when he's doing exams, his mouth ulcers get worse, so I actually reduced the dose in him. So again, the thing I want to put up with this is that this is an ongoing process. You don't just start the drug and say, see ya. It's a lot about making adjustments depending on people, how they're going as individuals. There are lots of side effects, and part of the discussions before we even think about putting people on drug is to go through what side effects people can expect and what to do when they get them, and simple things that might make things better. In our series, we've had one case of pneumonitis, and again, I look after people who often live quite remotely to our hospital. And this woman kept seeing her GP, you know, with a cough and shortness of breath and a cough and shortness of breath. And eventually, when she rang me and said, "Well, you better come and let us have a look," and she had pneumonitis from this drug, which is a particular type of lung infection. That went away completely, absolutely fine. And we did put her back on drug months and months later, and she's doing fine on the lower dose. We have had problems with worsening of headache. We had one case of severe behavioural disturbance, and in fact, this is the only patient I've had who has not been able to tolerate any level of the drug. And we don't know why, whether he had headaches, what it was, but he wasn't able to tolerate it. Have one man who has proteinuria that I'm watching, and of course we see multiple ulcers. Once we get people stable, I then try and drop back their MRIs to sort of like a 12-monthly schedule. But again, that's individual, depends on what people need. So I'm just going to finish up very quickly, and then I'm happy to take questions with a couple of cases. This is one of an absolutely delightful girl who's absolutely delighted to share her story. In fact, the more often I tell it, the better she likes it. So she was 16 when I first met her. And she had renal involvement. She also had CNS lesions, lots of seizures. She was attending a special school, eye involvement. She'd had cardiac lesions as an infant. She was on topical rapamycin for facial lesions. And she had lots and lots of behavioural disturbances and mood and anxiety, etc., which was difficult for her. But her big problem was that she had this huge right renal AML which extended down the renal vein and into the big blood vessel that goes up to the heart, called the inferior vena cava. So this was a lesion which had gone out of the kidney, down the vein, and was heading upwards. People were terrified about what this was. And not only were they terrified about what this was, they were terrified about what they might do about it, all right? So before Everolimus was available, this would have involved taking that whole kidney out, taking part of the major vein called the IVC out. They didn't even quite know how they would tackle this as a procedure. So she was sent to us to see what we thought. One, because one of the surgeons I work with is a fabulous surgeon, and he was in fact referred to her as a surgical candidate. How will you tackle this? What surgery will you do? Because they do this in renal cancers where they have to involve in getting tumour out of the IVC. So he then sent her to me. And this is a picture of it here. I'm sorry, MRIs are great if you're a radiologist. They're not that great if you're a renal physician. So this is the kidney here. You can see lots and lots of AMLs. But here, can you see that tongue of tissue pointing out into that major? This is the IVC, the major blood vessel. And that bit of tumour definitely should not be there. So anyway, we gave her Everolimus, and over time, it went away. All right, so we gave her 10 milligrams, and she was on all the usual anti-epileptics. So I have to confess that every time people come to my clinic, there's some new one I'd never heard of. Can't spell it, don't know what it does, look it up. And so we had trouble getting her levels up. And at the beginning, we were trying very hard to get to the target levels that were reported. And again, there's lots of work to be done on what target levels should we look for, can we get there, and so on. We've struggled to get them to the levels that are recommended in the EXIST-2 trial, I must admit. But we did push this hard. We pushed her really hard. She was an absolute trooper, this girl, in terms of what tolerability she would take. And so the first 3-month scan on 10 milligrams a day was better, definitely better. It had regressed to about the line of the renal vein. We were happy, but we thought we could do better. And we gave her 15 milligrams a day. And by 12 months, it has gone, and it has stayed gone. It's fantastic. And that's an absolutely terrific outcome for that girl. And she's done very well in lots of other ways now, so she's very happy. So this is, again, another typical patient that we get to see. So now that people know that we run a clinic, they know the drug is available, it's about whether or not you shouldn't give the drug. And that's why I've put this up here. So this 46-year-old man had been monitored for years and years and years in the urology clinic, having CT scans and ultrasounds and MRIs. He'd had trouble in the 1990s, okay? He'd had embolizations, and we'd scanned him again, and he has had no change in these very large lesions for more than 10 years. He's already got some proteinuria. He was very anxious about the side effects, and we explained to him, we said, well, look, we've got this drug, let's talk about it. You've been referred here to talk about it, so let's do that. And he's going to elect not to have drug, and we'll continue to monitor him. And I don't think that there's any real evidence, even though he's got this huge lesion, that we should try and treat that. All right? But that's my personal opinion. Because I think there is an age trajectory where things grow fast. That's when you need to treat, okay? And then when we pick up the legacy effect of, people who are out there with these big lesions who've been through that risk period, is just to continue to not harm them by giving them drugs that cause mouth ulcers and have other serious side effects. And in fact, he's got abnormal blood sugars, and I think if we gave him this drug, we might even make him diabetic, which would be a poor outcome. So there are so many unanswered questions. So when to start it, and it always involves a careful consideration for an individual patient, what the risk versus the benefit is, and that can be the whole spectrum of the practicalities of having blood tests, versus the risk of the boy who swims with his infections and so on, how you might manage that. The dose does depend on what other medications that they're on. Use clinical effect rather than the trough levels now as my goal of therapy. What do you do when the lesions are stable? Like, you know, my 17, 18-year-old girl now with that lesion in her IVC, she's staying on a higher dose because I was so worried that that might come back. But some of our other patients, we've dropped the dose down a little bit, particularly the boy who's at uni with mouth ulcers. It was really being a major problem for him. How long? And I think the other thing is that what about the progression of kidney disease itself? There are a subset of people who end up on dialysis because they have abnormal kidneys. It's very often because people have had bits of their kidneys embolized or cut out because, you know, there was one lesion that looked like cancer or whatever else, but not everyone. So this is a completely unanswered question, I think. So I did talk already about kidney cancer, just to change tack, because it is, of course, a very great concern. And it can occur in children, and it's very important to monitor and be aware of it. Growth rate does help, experts help. Like, this is where we really get our expert radiologists to look at the pictures and to look at the pictures across time, and our urologists. And these, of course, do need surgery, and the surgery is to try and spare as much of the normal kidney as is possible. And I talked about the cysts, which are very common. Polycystic kidney disease as a combined phenotype with TS is very uncommon, and it's reasonably easy to pick on the ultrasounds. I won't put that up there. If you're a radiologist, you can clearly see that that's polycystic kidneys, all right? Everybody else just looks like a storm. Looks like a weather map with some clouds, really, but believe me, that is truly polycystic kidneys, and they'd pick it, and that's just another picture. Much easier on the CTs and the MRIs. So just to summarise now, so the kidney is very frequently involved in this condition, and while sometimes this can be severe and associated with very significant complications, a lot of patients are asymptomatic, okay? That doesn't mean you shouldn't have treatment if you're asymptomatic. Of course, the goal is to try and pick out the people who are going to head to trouble and treat them before they get there, but we're still not quite at the point where we've got a really great test of working out, right, this is trouble, treat, these people are going to be okay, and don't treat. So that's what I reckon my goal for the future would be, to be able to spin out those people who really need treatment. Until we have a cure and can make these cells go away, bring it on. Assess and monitor, so that's a no-brainer really. Got to discuss the risk benefits for patients as an individual. We try and avoid preemptive embolization. We will do it, of course, if people present with bleeding or pain, or there are very high risk reasons. I don't think in the time we've been doing this have done a nephrectomy or a partial nephrectomy on anyone, and that's our goal. In fact, some of our job, we think, is to offer this service to stop that from happening. And we just keep getting that message out there. Don't operate unless you've got zero other choice. But if you need it, you need it. But that's really got to be worked out. mTORs are beneficial, very beneficial. It's great to have them. We've seen some great results from them. But we are really still learning how to best use them. And that's the end. Thank you.